Welcome to the CGA-IGC podcast series, brought to you by the CGA-IGC Education Committee and made possible through the generous support of our sponsor, LS Cancer Diag. Each episode aims to bring you an in-depth discussion related to emerging data, clinical challenges, and unique perspectives in the world of hereditary GI cancers. Before we start, we'd like to remind you that the content of this podcast is not intended to replace professional medical advice, diagnosis, or treatment, and the content reflects expert opinion at the time of recording. Keep listening to find out more about this episode's host, guest, and feature topic. And be sure to learn more about our sponsor at lscancerdiag.com.
My name is Dr. Julie Yang, and I'm an advanced gastroenterologist, Director of GI Cancer Services and Outreach, and the Associate Director for the Center of Carcinoid and Neuroendocrine Tumors at the Icann School of Medicine at Mount Sinai in New York. I will be your host for today's episode. We will be speaking with Dr. Toni Seppälä, who is a gastrointestinal surgeon, professor of cancer research, chief physician for developing personalized cancer management at the University of Tampere in the University Hospital in Finland. Welcome, Dr. Seppälä.
Thank you, and thank you for the invitation.
We're looking forward to discussing your research findings today. His group recently published a study in the February 2023 issue of Frontiers in Oncology entitled Clinical Characteristics of Pancreatic and Biliary Tract Cancers in Lynch Syndrome, a retrospective analysis from the Finnish National Lynch Syndrome Research Registry. This is a multi-center retrospective study looking at the clinical features of genetically verified Lynch syndrome patients diagnosed with pancreatic cancer or biliary tract cancers over 38 years between 1982 and 2020, which is the largest cohort of Lynch syndrome patients with these cancers to date. The registry comprised of 1,800 verified pathogenic variant carriers from over 400 families. So, Dr. Seppälä, to start, what was the importance of this study and the primary goals of what you were looking at?
I think given the long traditions that we have in the Finnish registry for over 40 years, we have gone through a long way from colorectal cancer and endometrial cancer studies. And given the recent results from the PLSD about the risks and incidences of certain other extracolorectal cancers that are more rare, but more lethal, led us to also inspect these things from our national registry. And given that we have relatively in-depth data on surgical and oncological management, we thought it would be interesting to publish a cohort of pancreatic biliary cancers, as well as we're actually doing similar work on other extracolorectal manifestations as well.
I agree. I mean, with these patients living longer, it seems, and we're finding the next sort of challenges of cancers, pancreatibiliary and biliary tract cancers are definitely of an interest. Have you seen in your registry over this time period that the incidence of these cancers was increasing?
I think the incidence data that we can derive is mostly from the prospective Lynch syndrome database at the moment. In the most recent update that we had was the publication in 2023. So this year in Clinical Medicine, where the incidence of pancreatic cancer was 3 to 4% by age 75 for MLH1 and MSH2 carriers, and slightly less, about 1 to 2% for MSH6.
Did you notice that the risk for these cancers varied depending on the mutations for the Lynch syndrome patients?
Yes, we did. So there's definitely a difference between MLH1 and MSH2 that have higher cancer risks in pancreatibiliary cancers. And it's virtually none for the biliary tract cancer for MSH6 and PMS2. And the risk is substantially lower for MSH6 for pancreatic cancer as well.
Yes, I saw if you actually go into the results, the MLH1 variant, as you said, cancers were found in 33 of the 39 patients, 21 out of the 26 with pancreatic cancer, 9 out of the 10 with biliary tract, and all 3 ampullary cancers that you guys described were the MLH1 variant. And the MSH2 patients, 5 had pancreatic cancer and 1 had the MSH6 for the biliary tract cancers, confirming prior data that particularly the MLH1, MSH2 are at higher risk. Did you find that there were other risk factors for pancreatibiliary and biliary tract cancers associated with Lynch syndrome?
Well, we didn't look into it, and I suppose we don't really have those data available. But as for your previous question about the shift in the incidences, I think when we look back about 100 years, we know definitely that the cancer spectrum in Lynch has evolved over time. So now, as you said, that people are living longer despite the more common cancers, colorectal and endometrial. I definitely think that we see a drift in diagnosing more of these cancers as well.
Do you think diagnosing these cancers, that's from us being better at detecting from imaging, endoscopy, or that these kinds of studies where we're aware that this is sort of the next generation of cancers that we have to be aware of, or is it both?
I would say it's both. I think from the biology perspective, it's really interesting. If the hypothesis that the upper GI cancers occur later in life these days is true, one would expect that we see an increase in the incidence, at least slightly. But of course, we are also imaging these patients much more extensively for various reasons.
So in your study, metachronous tumors were diagnosed in 70%, with colorectal cancer as the most common metachronous tumor, diagnosed in 51%, endometrial cancer in 8 patients, and they were all diagnosed prior to pancreatic biliary cancers. So it's interesting in what we're talking about, that this is later presentation, it seems, and that we're imaging more and more aware of these cancers that occur thereafter the fact.
Right. And I think this temporal order of events in Lynch syndrome is really fascinating. And at least in my mind, it also reflects the underlying biology. So I think it plays together very well with the hypothesis that the immune response is somehow involved. So the more common cancers may serve as sentinel cancers, that the immune response is now somehow worn out and people tend to get these first common cancers. Mm-hmm. And perhaps that could serve as some kind of clinical indicator that maybe these less frequent cancers occur next. And this could be an opportunistic way of hearing out what the patient's complaints and symptoms are and act accordingly.
Right. That brings up a good question and point about being vigilant about these cancers in these patients, particularly after they've had colon cancer or endometrial cancer. Would you say that your study findings, one way or another, can point or change the impact of screening or surveillance in our Lynch patients?
I wouldn't draw too strong conclusions for any of the surveillance based on these data in this paper. But of course, there is emerging evidence about the incidences, and I know worrying for both the clinicians as well as the Lynch syndrome carriers. So definitely knowing more in depth what these pancreatic biliary cancers are, what their risks are, and possibly about the biology, what the precursor lesions might be. I think it opens opportunities for research, prospective and registry approaches to deal with this issue. I think it's not straightforward to say that surveillance is definitely needed.
Right. There's definitely differences in opinions and the U.S. guidelines for particularly screening for pancreatic cancer in patients versus the European guidelines. So I definitely agree that there's much to be learned, and tailoring our approach to screening surveillance of these patients is still up in the air for questions. Going back to the patient population, what would you say, what was the average age of onset of the Lynch syndrome patients with these cancers?
Well, in this paper, it was some 64 years for pancreatic cancer and 54 for biliary tract cancers. From the previously mentioned eClinical Medicine paper, the PLSD data shows about 65 to 67 years of age for onset in MLH1 and MSH2.
Can you talk about more patients, how they were managed with the cohort that was the operable patients and then those that were inoperable, and the differences in the prognosis of them?
First of all, less than half were operable at presentation, 40% of the biliary tract cancers and about the same of pancreatic cancer. As a traditional estimate, one would say that it's 10 to 20% in pancreatic cancer and some 20% in biliary tract cancer in sporadic setting. So definitely these were higher numbers. I know that these figures have come up a little bit also in sporadic cancer in recent years because of more aggressive surgical approaches. But I think that in this case, since this is somewhat historical data, it reflects to the 10-20% that it would normally be. So perhaps this is biology, but of course it is also earlier age of onset. There were only, I would say, 6 pancreatic cancer patients that were over 70, and in total, 9 out of 39 were over 70.
Is there a time period, or did you guys look at the time period of presentation from the time they had presented with their first cancer to the time they presented with pancreatobiliary tract cancer?
We didn't look at exactly, at least I don't recall it right now because it wasn't in paper, but definitely this temporal order and the delays, how quickly the next metastatic cancers occur is of interest. And it's at the moment being studied, for example, in the PLC.
Yes, I think that would be a key information piece to help future screening surveillance guidelines if we can know what the average temporal time period is to when these patients develop their secondary cancers. Interesting also is that the 3 ampullary cancers that were found all underwent surgery and were operable, but disappointingly had a survival of 1.5 years, which I thought was very interesting.
Right. I think that the ampullary cancer in general is an interesting sidetrack in the material. We know that there are duodenal small bowel cancers in Lynch, and that they do occur. And in fact, they are actually very frequent compared to how often they should occur in sporadic setting. I think ampullary adenocarcinomas are histologically a little bit closer to small bowel cancer, but since they are anatomically located where the other cancers of interest were, we decided to include them as well. And of course, it's only 3 cases, but it shows that it's a severe disease, very bad prognosis.
Yes, yes. What was so interesting about even just those 3 patients, and as a gastroenterologist, makes me think that when we're doing screening for upper GI cancers, should we be particularly looking at the ampulla like we do in our polyposis patients?
Well, it's hard to say. It's only 3 patients in this case. It hasn't been that granular data elsewhere. So if we came up with other reports, maybe it would be worth looking into. But obviously, like good inspection in all surveillance, also to papilla would be important.
Yes, yes. And the next question would be the patients, but other than talking about surgical options, what do you think the direction of therapies would be for these types of cancers, particularly looking at the role of immunotherapy?
Well, I think this is the very core of what people are studying at the moment. I think that the immune checkpoint inhibitors are a major game changer, especially for advanced pancreatic biliary cancers. I think that given the data that we have now, the median survival has gone up, skyrocket, and that's mainly because of immune therapy in this patient group. Apart from the Keynote 158 that actually showed not that good response for pancreatic cancer, it was some 18% objective response rate. There are a couple of other reports like the AGIO European cohort of 31 patients that showed ORR of 48%. And of course, the Hopkins paper in Science in 2017 that showed 62%. So I think these are really good numbers for initially inoperable cases like they did. And I would especially highlight from the surgical perspective, the high number of stable disease and partial responses that occur quite frequently, much more frequently than complete responses. And they may open opportunities for surgical resections in settings that we normally don't see them.
Yeah, I think that also brings up a good point that, these patients are complex with multiple factors and need to be discussed in a multidisciplinary setting to discuss all of these options and optimizing their oncological care.
I agree.
Yeah. And thinking about final thoughts, what research do you think would help fill in some of the knowledge gaps in pancreatobiliary cancers and Lynch syndrome? We sort of talked about time frames. We talked about immunotherapies. Anything else that you would think we would need to know and what's really on the horizon for what we need to know?
First of all, we need more up-to-date prospective registry data on how immunotherapy is currently working for these patients. We need more detailed data on clinical pathological features and the tumors and why some responded, some didn't.
Right.
And especially, I think we need better data on surgical outcomes as well. I would like to see how immunotherapy would play out in the adjuvant setting or neoadjuvant setting in this very difficult cancer types. And of course, I would say in the US, the tumor testing is on the right track. You're definitely doing better than in Europe. This practice of testing upper GI tumors comprehensively is not as good in Europe. And I think we need much better data on how often pancreatic and biliary tract tumors are mismatch feedback deficient, what their other profiles, transcriptomic and genomic profiles are.
Yeah, a lot to look forward to, and hopefully we'll have some new information and make more segue, including the information that's from your paper. I want to discuss last main takeaways for our audience from your registry study.
I would possibly highlight the survival of these patients. I think they are in line with what we know from the PLSD. The pancreatic adenocarcinoma itself, it's not cancer of good prognosis. We are talking about some 17 to 20% 5-year survival rate, but it's still much better compared to sporadic when we're talking about 10 to 11%. However, the cases that were amenable to surgical resection, the survival was close to 40% for 5 years. And the same for the biliary tract cancer. It was only 4 cases, but 3 out of 4 made it for all 5 years. So I think it's looking really good. And there might be something related to the biology that we need to know a little bit more about.
Yes, there's definitely a remarkable difference in the overall survival for the patients who were resected and those who were not. It opens the door for the biology. It opens the door to the screening surveillance we spoke about and further understanding which mutations and immunotherapy can play a role here. But yes, definitely a lot of room for improvement.
Right. Because to me, it looks like the cases that are not good for surgical resection actually do just as poorly as the sporadic cancers do. So I think this is worth looking into.
Yes. The overall survival for those who were not treated with surgical curative intent was all less than 1 year, which is in line with sporadic cancers. But thank you so much, Dr. Seppälä, for your insights and contributing the information for Lynch syndrome patients. And we will all be looking forward to the next phase of your research. And we will all convene at the next CGA-IGC podcast. Thank you, everybody.
Thank you for the opportunity.